The views expressed in this podcast are my own and those of my guests. They do not represent or reflect those of UCSF Health or my professional and clinical roles there. The content is intended for informational purposes only and is not medical advice. Please consult a qualified healthcare professional for specific medical guidance. Welcome back to In the Loop with Nadia Vlasiuk. Today we're talking about electricity, cardiology, and the long path it takes to become a heart rhythm specialist. My guest today originally thought he would become an engineer. He loved math, physics, and electricity. But instead of designing circuits, he now spends his days mapping electrical pathways inside the human heart. I'm joined by Dr. Joe Kewcharoen, a second-year electrophysiology fellow here at UCSF. Dr. Kewcharoen grew up in Thailand and graduated from Chulalongkorn University before moving to the United States to pursue postgraduate medical training. He completed his internal medicine residency at the University of Hawaii and went on to complete a cardiovascular disease fellowship at Loma Linda University before beginning his clinical cardiac electrophysiology training at UCSF. In addition to his clinical training, Dr. Kewcharoen has been extremely active in research with more than 100 peer-reviewed publications during his medical training. His academic interests include electrophysiology procedural outcomes and safety, sudden cardiac death in the community, and arrhythmogenic syndromes such as Brugada syndrome. In this episode, we talk about what the journey looks like for an international medical graduate entering the U.S. medical system, and what it takes to match into highly competitive specialties like cardiology and electrophysiology. We also explore the role fellows play in patient care at academic medical centers like UCSF. Electrophysiology fellows are already trained cardiologists who work closely with attendings and the broader care team to evaluate patients, perform procedures, and help advance the next generation of heart rhythm therapies. Dr. Kewcharoen also shares what makes electrophysiology such a fascinating field, from interpreting complex electrograms to performing intricate procedures that treat life-threatening arrhythmias. If you have ever wondered who the physicians are behind the scenes during procedures like ablations, pacemakers, and defibrillators, or what it takes to become one of them, this episode is for you. Thank you so much for joining me today, Joe.
Thanks for having me.
Of course, of
Super
course.
excited.
For listeners meeting you for the first time, which everyone should be, what stage of training are you in right now?
I am a second-year fellow in EP, or that stands for electrophysiology.
Yeah, most people here know what EP is now because I've said it a million times.
Okay.
Yeah, we call it EP. You're right. Where are you originally from, and what first drew you to medicine?
Yeah, I was born and raised in Thailand, and that's where I grew up. Funnily, I didn't grow up wanting to be a doctor.
Really?
Yeah, I grew up enjoying math, physics, electricity. That was actually my favorite topics. And throughout middle school, high school, I wanted to be an engineer.
Really?
And I pivoted last year of high school. You know, my parents, they're both physicians, and they weren't the one who like pushed for it. Like my cousin, like, hey, you should, take an exam for it, because that's how we get into medical school in Thailand. We take exam, like a standardized exam, and like whoever get the highest score get to pick what major they want to do. So it was my cousin who like, hey, you have good grades, you've been doing well in high school, you should try take the exam. I was like, I'm not going to be a doctor. Why am I taking it? And they were like, well, think of it as a practice exam for an engineer and stuff. So I'm like, okay, fine. And I took it. I got in, and of course, they was like, you got in. Are you going to really let the opportunity go? So, and then, a few things happened. I changed my interest, and it was like the second half of my senior year that I decided, okay, let's just do medicine.
Yeah. Very cool.
Yeah, and I did not regret it.
No, well, it's cool that you were into electricity and now you're doing electricity.
Yes, that's a lot. I think I'm just very fortunate to, know what my passion are. And I found things that have all my favorite things in. It's a lot of math, in EP, a lot of physics, a lot of electricity-ish stuff. So I'm very happy that the field exists and exists in the way it is.
Yeah, that's amazing. When did you realize you wanted to do cardiology?
Well, it was very early on. It was my second year of medical school when we learned about physiology and hemodynamics of cardiology, and that really drew me in because there was a lot of physics and physiology and, things make sense. So that drew me into cardiology. And I think my clinical years when I started learning how to read EKGs is really fascinating. And I think that what got drawn me into cardiology and especially EP. You know what Brugada is, but for listeners who don't know, it is a very rare genetic heart disease that nothing shows up in a physical exam. Sometimes they have no symptoms. You diagnose it purely on the EKGs. It's very prevalent in Southeast Asia, and Thailand being one of the country that the disease is very common. The hospital I trained during my clinical years in particular, every week we'll see at least one EKG with Brugada.
Wow.
And yeah, just the way my attending at the time walked me through the EKGs and like, why is this translate to Brugada and what happened in the heart and, depolarization, replacement channel and all that. That it's just fascinating to medical students.
So that's kind of where you went from cardiology to electrophysiology then?
Yeah. Well, I must say my understanding of EP back then was very different than what I understand just a few years ago. Like back then I thought EP just expert in EKGs, expert in AFib, expert in amio, which they are.
Yes.
And it's just more than that. And it's not until like my second year of general cardiology that I learned that EP is actually like very different, very, very procedural heavy. There's a lot of thinking, a lot of puzzle solving, EGMs, which stands for intracardiac electrograms. Think of it as an advanced version of EKGs that you need to learn to interpret. Then procedure is very long, from 2 hours to all day. But yeah, again, I'm very happy that the field is the way it is because I also like doing procedure. I like playing video games. I'm not saying procedure, patient's life is like video games, but it kind of had that feel, You do certain movement, you're trying to achieve a goal, and you clear that goal, and you move on to the next step, and all in the hope that you complete the procedure and get the patient through safety.
Yeah, I've never really thought about it like that, but it really is kind of like that.
It's kind of like that.
Yeah. Well, it's nice because you get like the clinical side and then you have procedural side. So there's never a dull day.
No. Like people are going to hate me if I say this, but during internal medicine, there were times that I was like, I'm so tired. We're going to go in and rounds, same thing over again. Even cardiology some days, but EPs in the past year and a half, I wake up every day feeling fresh and excited what case I'm going to get today, what I'm walking into. I mean, if it was a day with 2 AFib, you can okay, sure, it's 2 AFib, but sometimes SVT devices, extract VTs, just get me up in the morning.
Yeah, that's awesome. It feels like being in a subspecialty, you think, oh, you just see the same thing over and over again, but you really never know what you're going to see. And everyone's version of it is just a little bit different. It's great. Can you walk us through what medical training looks like in Thailand compared to the United States?
Yeah, of course. In Thailand, we go into medical school right after high school.
Okay, wow.
So we don't do undergrad. From learning from all the international medical grads from around the world who are here in the US, I think majority of the world are like that, where you finish high school and then you go directly into medical school.
Wow.
Although it is longer, it's 6 years and not 4 years. So I got in right after high school. The first year we went through physics, biochemistry, and all that. I think similar to what you would do here as a pre-med.
Right.
And then you finish that, you cram it in 1 year. And then our second, third, fourth, and fifth year, I think very similar and equivalent to the 4 years of medical school. And our last year, then we basically function as an intern. We rotate through major rotation like surgery, internal medicine, pediatrics, OBGYN. We function as an intern. We rotate through the emergency room. And that's kind of like the last year practicing stage before you go out and work as a physician in Thailand.
Okay.
Is that how it is? You are not forced to go into residency. And should I explain what residency is?
Yes,
okay.
Please do.
So, after you finish medical school, then you need to choose a specialty to go into, and that is residency. So you think of medical school as like a root of the tree, and then you come up as a main trunk. And then specialty/residency is the branches of the tree that you can choose. And the main residency that I think people are going to be familiar with would be internal medicine, pediatrics, surgery, OBGYN, ortho, urology, ophthalmology, radiology, ENT, etc. So in Thailand, when you finish, you work as a general practitioner.
Okay.
And you choose whether you want to come back to do residency or not.
Okay.
So you can practice for a year, 2 years, 3 years, find yourself, and then you come back to do residency later. Whereas in the US, it's required that you choose residency before you finish medical school and then go into do residency. I think that's probably the main difference.
Okay. How is the United States different? So they do undergrad, they do pre-med, so they end up with a bachelor's degree and then go into medical school. And then how long is medical school typically in the U.S.?
4 years.
4 years, and then you go to residency.
Then you go to residency, and after that, it's the same.
Okay.
And I think the training in residency in terms of duration and like the specialty and the subspecialty after that, which is called fellowship, are kind of the same, I think. Very similar in terms of structure and the main choice that you have.
Okay, great. What were the biggest hurdles in transitioning into the U.S. system as an international medical graduate?
Yeah, I wouldn't say there's any major hurdles, but I can say that some things were quite challenging to me. And I would say, I think the first few months when I get into residency in the US in internal medicine was, I think the culture was just very different.
Yeah.
And I think there's also kind of follow-up to your question from before about the differences in medicine in Thailand and the US. I think like the way you talk to patients, the way you talk to your attendings, the ways you talk to your other team members, your other allied health professionals, they're just different. And I think it took me a while to kind of adapt to this change. Like to give you a concrete example, in Thailand, physicians are viewed as some invincible Superman with an IQ of Einstein who's supposed to know everything. Like I literally need to know if I want to give a vancomycin, what dose, in what saline bag, how many cc, and drip at how many cc to get whatever milligram per kilo. So like mix the levofed. And, I still remember we were taught the formula to calculate how many milligram of norepinephrine to mix into like a 250 of saline and drip at how many milligram, all that. I memorized all that. And when I start training here in residency, like I prepare my presentation, I was ready to give my mix of ceftriaxone to like my attendings. And she was like, what are you talking about? We have pharmacy. We have team member here. They can help you. You don't need to go try to do physical therapy to the patient yourself. You have PT that help you.
Right.
And, you don't need to draw the ABG yourself. You have the phlebotomist or respiratory therapist who help with that. I think those just are the main difference that in the US, you are more of a part of a team. You can be the leader, sure, but everyone as a team and you work as a team and we all have one goal is for the best of the patient. And we are good at different things. We do at what you're good at, and then we do our best for a better patient outcome. Rather than in Thailand, you're supposed to do everything, supposed to know everything.
Yeah, and that's a lot of pressure too.
It's a lot of pressure.
You mentioned attendings. Do you want to explain the difference real quick between like residents, fellows, and attendings?
Yes, of course. Attendings, physicians who already went through the training before you and now work as a supervisor to trainees that come after them. So for example, if I was a resident in internal medicine, I went through training, which is 3 years. I finished training, I can work as an attending. And my job would be see patients as, fully trained physician, but also supervising the resident who came after me. And that one day they'll finish training and they'll become attending and they'll supervise the next resident. And that is a training culture of medicine.
Okay, that makes total sense.
Another thing that I would say a big change is the electronic medical records. I went to medical school in Thailand. This is over a decade now, but back then we're still using paper charts. So you write progress note in paper, you order in papers. You have 2 columns, and then on the left column, you write down a single time order. For example, if you want to give an IV dose of Tylenol one time, you write that on the column on the right, you write down that you want to be continuous. For example, vital signs or, check INO every day. And like, every week you need to review the orders because every day you write the orders, right?
Yeah.
And you check lab every day. You need to write down CBC, electrolytes. BMP is not a thing in Thailand. You do electrolytes and you do BUN, creatinine. Like EMR is a big changes, and I think it benefit physician in multiple ways, but one of the things I feel like that helps me a lot is I can get much more information from reviewing patient's chart. I can review patient information from home, get ready from clinic, and I can see notes from other specialties and see what are things that are happening with my patient, because obviously the patient doesn't just have heart disease, they have other things. And I think this really allowed me to be thorough and check everything about the patient, look at patient as a whole. You can check labs 20 years ago, what it was like, whereas, it's a paper chart you need to go through.
Where would you even find it?
20 years ago, paper get torn off, sometime it got wet, and So that is one of the big thing that I need to adapt to, but in a very good way.
Mm-hmm. Yeah, definitely. With those hurdles in transitioning, was there a time when you didn't think that you would make it into what you wanted to do?
There were times. Cardiology is very competitive. The match rate vary year to years, but overall it's around 60 to 70%. Meaning if you have 100 applicants, only 60 to 70 applicants will match, and the rest will go unmatched, and they couldn't do cardiology. They either try to apply next year, do something else to improve the CV. But anyway, that number was a combination of people who did medical school in the U.S. combined with people who did medical school outside the U.S.
Oh, wow.
So for the U.S. graduate, the number is probably higher. And for me, who did medical school outside the U.S., the number is probably lower, like close to 50%. So like a coin toss. So there's a lot of pressure on me to do research, do well during residency, get good letters. It's a lot of pressure, and you didn't have a lot of time. Residency is 3 years, but you start applying by the beginning of your third year. So basically you have 2 years to prepare. And then like if you want to put research out, it takes like 6 months to publish a paper, right? So really, you only have like a year and a half to like start from scratch. So I worked really hard, and I tried to get my hands on everything. I didn't come from the residency program that is world famous. There was times that I was anxious, but hard work paid off.
Yeah. Where did you do your cardiology fellowship?
Oh yeah, I never mentioned that. So I did residency in Hawaii.
Okay.
And then I did cardiology at Loma Linda in California.
Okay. Correct me if I'm wrong. Your residency was just internal medicine.
Correct.
Okay, so you did internal medicine in Hawaii. Which island?
Oahu.
Okay. And then you did cardiology fellowship at Loma Linda.
In California, yeah.
Great.
Southern California.
Okay, yeah, that's awesome. So you just described your residency, which was your internal medicine training. And then you went to cardiology fellowship, where when you're through with the cardiology fellowship, then you can be a cardiology attending, right?
Yes, you can.
Okay. Or you can apply for another fellowship.
Why not?
And you applied for electrophysiology fellowship here at UCSF. Okay, great. And we're so happy to have you. I'm so glad you're here and on our team. How long is an EP fellowship?
It is 2 years. It used to be 1 year with some programs doing 2, but for the past decade or two, it has been a mandatory 2 years.
Well, I'm glad you've been around for 2 years now. So
Year and a half already, yes.
I know, right?
Time flies.
So what does an actual week look like for you?
EP specialty is very heavy in doing procedure. Not like a full-on surgery, but more so a procedure. And we do it in the operation room, what we call an EP lab. Different programs will have slightly different structure, but the majority of the time of an EP fellow will be in the EP lab doing procedure or helping attending doing the procedures. At UCSF, we have 6 fellows. And 4 fellows going to be in the EP lab at a given time. And 1 will be on protected research time, and the other will be on consult service. So if you're on EP lab, your daily routine is you come in the morning, you see the patient who is going to get your EP procedure that day. You talk to the patient, get the consent, and make sure that the procedure is indicated and there's no major contraindication to the procedure. And our team, other NPs and all the attendings that already did a fantastic job getting the patient to come in, like make sure they have indication for this procedure, and we all, make sure there's no contraindication. But, sometimes minor details slip past through, and you're seeing 20, 30 patients a day, and so does everyone.
I only see 11 or 12, but thank you for that.
But I think we kind of, in a way, work as a last line, make sure that before the patient physically got on the EP lab, that everything is in place.
Right.
Then you start the procedure, and when you start, attendings may let you do just a little bit at the beginning and, they supervise you, they teach you how to go through this procedure effectively and safely. And as time goes on, you take on more responsibilities. At least for us at UCSF, the culture is to have fellows do more than average. By the second half of the first year or beginning of the second year, you're pretty much doing every procedure almost from start to finish.
That's great. And just for those listening and anyone that might be going through an electrophysiology procedure at an academic center where there are fellows are already cardiologists who are training to be electrophysiologists. I sometimes have patients that say, I don't want a medical student doing this procedure. And I'm like, I can assure you there are none doing them. And they are already cardiologists and they're working with the attending very closely. They're together in the room. I think that makes them feel a lot better.
I do get asked that from time to time, like, are you medical students? Yeah, the answer, like you said, no, I finished that 7-8 years ago.
Yeah. And not that there's anything wrong with letting people be trained, but the procedures that you do are so precise that, having this training and skill already, I think that really does make a difference. Our fellows are very highly trained and then our attendings are there with them. And that's how you learn. And then you get to be an electrophysiology attending.
Yes. So like we talked about before, that after 2 years now, you can graduate, you become an attending, and now you supervise the next generation of fellows.
Yeah, it's great. How do EP fellows work with NPs, PAs, nurses, and other hospital staff in real life?
Lab staff, nurses, PAs, NPs, attendings, we all on the same team and all of us are involved in the procedure as much as the other one. For staff and nurses particularly, they'll help you prepare the case. They'll help you prepare the equipment, help you, for example, help with the connections, connect your catheter to the monitor, the generator, etc. And when you need more equipment, you only have 2 hands and you're already sterile, so they need to open up new stuff. And sometimes, not at UCSF, but at other institutions that I've heard, that sometimes a tech will scrub in with you or they will help with the computers manipulating the stimulation. It's the part of the procedure that we do, like stimulating the heart, trying to get the arrhythmias going. So they're very heavily involved with that. Even after the care, here at UCSF, we have PAs and NPs who help with the post-procedure care. Yeah. And they're very, very essential. And I can't stress enough how relieved I am to have them, taking care of my patients and, stay overnight and help with the discharge stuff, making sure everything's set in place. So yeah, I think we work very closely with them.
Now that we know what an EP fellow is and how you work with the whole team, what do you wish that patients understood when they hear a fellow will be involved in your case or your care?
Yeah, I want them to rest assured. Like you said, we train in internal medicine, that's 3 years, cardiology, that's 3 years, and we did procedures during those training. And the procedure we do in EP is a build-up from those procedures that we did in the past 6 years, getting to this point. So we already train. We just here to train more, to get familiar and efficient and get to the more advanced stage. And with that, we have attending who really supervise you, look at your every movement. Yeah. You can move your wrist and they would know. And we have X-ray, we have ultrasound, we have our mapping system that we use. So it is very safe. The fellows, they care a lot because we want to be a good fellow. We're here to learn. We read up on the patients we're going to do procedure on. So I just want patients who are listening to rest assured that we are doing our best. We're here for you, and we work as a team with the attending.
Yeah, that's great, because I have patients who always ask, well, Dr. So-and-so is going to be doing my procedure. And I'm like, yes, absolutely. But he will be accompanied by one of our electrophysiology fellows who is already a cardiologist who is training to be an electrophysiologist. And they always feel better because sometimes they're like, I just don't want some random medical student. I'm like, no. These are highly trained, amazingly skilled physicians who know what they're doing. So
thank you for saying that.
Of course, my pleasure. I mean, and I don't think people don't really get to see it. I do, because I work with you all, but we have conferences every morning where you guys are presenting. You're being asked questions. You're being put in the hot seat. And sometimes I'm so nervous for you because I'm like, all the attendings are like, so what does that mean? And you're like, no, they all do really great. But yeah, it would make me nervous as heck. So
well, we were. I was. I mean, I'm second year now. I don't get that much anymore. But I must say it was a very good learning experience.
Yeah.
Yeah.
So what electrophysiology procedure do you think is most misunderstood by patients?
That is a very good question. I think most commonly it was the pacemaker and defibrillator placement that got misunderstood by patients. And the part that was misunderstood was when people hear this, they thought now the heart is going to be living off a machine.
Yeah.
I had that. I had that not uncommonly. I would say 1 out of 10 or 15 would ask that question. So for listeners at home, pacemaker is a device that make the pace of the heart. So in layperson term, it treats the slow heart rate. So when your heart drop below 50 or 60 or wherever you set at, it will pace your heart. And it does just that.
Yep.
For defibrillator, as the name suggests, is defibrillate. It shocks your heart. So when your heart goes into life-threatening arrhythmias, the medical term is called ventricular tachycardia or fibrillation, and these are very dangerous life-threatening arrhythmias. The device will deliver a shock or defibrillate your heart, bring you back to normal rhythm. And it does just that. When we say that you may benefit from a pacemaker or defibrillator, it does not mean that you're living off a machine.
Right.
You just have this as an insurance. It will prevent your heart from going too fast or going too slow, and as an insurance, and that's just it. And we have patients who have it in and never get to use it.
Right.
You know, and that's good. Patient might say, well, why did you put it in me? Why did I need to use it? But we don't know, right? We all have insurance. We don't know when we're going to crash our car. We just need it. There are patients who have a what we call complete heart block, and they would need pacing 100% of the time. And that is probably as close as living off a machine as you can get. We put it in as a insurance, a backup plan. Right. Because your heart can stop for 10 seconds, you may pass out, and if you pass out in bed, that's fine. But if you are driving or swimming, that can lead to, more catastrophic loss.
Right, absolutely. And I do want to clarify one thing. Pacemakers do not control how fast your heart goes. If your heart's going really fast, because I have patients who say, well, doesn't it slow my heart down? No. Pacemakers do not. Pacemakers only keep it from going too low. And then defibrillators can also work like pacemakers, but they have a shocking coil.
Yes.
That is the one fast heart rhythm that they can help go back to normal rhythm. But it's not that it just slows the heart down. It actually shocks it into normal rhythm.
Yeah. And one other thing too, you mentioned a good point. The defibrillator, we wanted to only treat VT and VFib. You can have many types of fast heart rate. And for us, as electrophysiologists, we don't just care about rate. You can be 150, but if you are, say, running a marathon, doing a high-intensity exercise, your heart rate is going to be that high. We don't want to shock you. But
no, we do not.
Yeah, but if you go into VT, even your heart rate is 120, we want to treat that.
Right, exactly.
So it's not just the rate, but also the rhythm. And same as slow, some patients say, hey, my heart rate is 50. How come you're not doing anything? But it's 50 in normal rhythm, like normal activation of the heart in a way, we don't want to do anything. But if you have, like I mentioned, a complete heart block, your heart rate can be 70, but we got to treat that.
Right, exactly. And this is something that comes up in my clinic a lot, is patients are like, should I be worried that my heart rate is 48 when I'm sleeping? Absolutely not. Does it make you feel bad?
Yeah.
No.
Yeah.
So I always tell my patients, low heart rate, low blood pressure, not a problem unless you have symptoms from it. So that's just one thing.
That is actually the second thing that patient misunderstood about this concept too. So yeah, we brought ourselves the two answers.
Perfect. What feels genuinely different about electrophysiology now compared to what you know about it even 5 years ago?
Well, 5 years ago, I didn't even know any EP. but from listening to attendings and it's quite unanimous that same as most things in the world, technology continues to get better as time goes by. But I think for EP specifically, we just recently had like a leap. We have a new ways to deliver energy to do ablation, and the energy is called pulse field ablation. the pacemaker realms also now we're shifting more toward not having a lead.
Right, yeah.
So usually you have a lead that travel from your chest down to the heart. It works fine, but it can be root of many complications and problems that come after. So as a field, we're trying to shift. So as a leadless pacemaker, I think these tools are probably the major breakthrough in the past decade.
Yeah.
And also, in addition to better ultrasound, better mapping, you do procedure faster and safer.
Yeah, less risk to the patient.
Yeah. And they say this is the great time to do EP. And I don't want to say great time to be a patient, but much better time to be a patient having arrhythmias now compared to 10 years ago.
Yeah.
And I think we'll continue to get better. I think the fields are in very good place. Just being in this field for just 2 or 3 years, I already see constant progression, development, new technology comes out every year. And I'm super excited what the field's going to be like in the next 5 to 10 years.
Yeah, and I love that you're excited because we see our colleagues that are excited, and it's so neat to see our whole team just like want to learn more and to help patients more and improve the care. So.
I'm a big nerd in AP. I'm not.
Note to everyone listening, most electrophysiologists, I would say all are big nerds.
Yes.
So that being said, what are you most excited to learn or master before your time here as a fellow is up, which is pretty soon?
Yeah. I think the thing that got me excited the most nowadays is doing VTs.
Really?
So the ventricular tachycardia. For listener, doing ablation of VT or the life-threatening arrhythmia that originating from the lower chamber of your heart is probably, I think, it's the most complicated procedure in electrophysiology.
Yeah.
I think patients are sicker, your procedure takes longer, the success rate is not high.
Right.
And, every case, it sounds cliche, but every case is different. And when you're doing a VT, it's like you going into a story. When people ask you, hey, how did your VT go yesterday? I can tell a story. Like, you have a prologue where patient have this substrate, they come in with this, the device detect this, and you have Act 1 where you prepare the patient, you put this many catheter in, you prepare this way. You go to Act 2 where you induce something, you do maneuvers, you interact with the arrhythmias, you're trying to figure out what it is, and then for the climax, you do ablation, and what was the result? You terminate, not terminate. There could be an aftermath where you induce another VT, and then, and then like the end, how did the patient do? Like you might have joined some of our conference where I present cases, and my co-fellows always make fun of me that I put a lot of effort into the presentation. I have animations, but I just enjoy, going through the case, going through the story, and tell the story to my co-fellows, my attendings, and tell them what was the story about, what I did. Being an EP fellow here at UCSF, we are a tertiary VT center. We got referral for a VT, and I think that's a very unique opportunity for me to learn from the best, and that 6 months that I have left, I'll try to do as much VT as I can. Yeah. I'm still excited about it, but there are reasons that many EPs don't do VTs in their life. I enjoy it now, and I'm happy to keep doing it, but we'll see in the future. But now I think that's what I'm excited most about.
Yeah, that's amazing. It's life-threatening arrhythmia, and
it is.
The more we learn about it, and like you said, the substrate. Can you explain what you mean by that? What's the substrate?
I'm sorry. I let out that term. So we all born with no scar in the heart. The heart is squeezing. The electricity is running through the heart fine. When you get older, you can have disease of the heart, or you can have what we call scar inside the heart. Think of it as a wrinkle on the face. Sometimes it's just old age that have it. Sometimes it happens after heart attack. Sometimes genetics. But when you have these scars, you have that wrinkles in the heart. Now your squeezing function is not the same. Your electricity going through the heart is not the same. And that can be a trigger for you to go into the tachycardia or VT or ventricular fibrillations. The different etiology of causing the scar. So if you have a scar from having heart attack, it's going to be a different scar from genetics or from old age or from past surgery of the heart, etc. So different substrate will lead you to a different type of VTs and will lead you to a different strategy in doing these ablations and how you approach this.
So the substrate is basically like the different changes in the heart tissue that cause the electricity to travel in a different way.
Yes.
Basically.
You sum it up very nicely. Much better than me.
No. It was a team effort. And because the only reason I know that is because I hear Dr. Shaw all the time. What is the substrate? What is the substrate?
That's all that matters. You know, these procedure, good preparation will already win you more than half of the battle.
Yeah. Absolutely.
Yeah.
Absolutely.
And I got that from Henry. He always have the quote, the phrase.
He does. You know, honestly, in my clinical practice, I think I quote him more than anyone else. But his quotes are solid. Like one of my favorites is, "We never want to make the cure worse than the disease," and that is just such a great philosophy. Like, why would I want to hurt the patient more to fix something that isn't bothering them that much? You know.
Another thing that I'm excited about, because technology is just getting better, this pulse field ablation, I think is going to really change the way we do VTs.
That's great. What do you find the most meaningful about taking care of electrophysiology patients?
Yeah, that's also another good question. Other than your usual joy of taking care of patients, seeing them get better and all that, I think what I find most meaningful was that when I told them about the complexity of the arrhythmias and the what we do during the procedures, what we have accomplished, and what we think going forward, how they're going to do in terms of arrhythmia standpoint, all of them were like, wow, I think they can sense my passion in this field. And I think they're like, wow, you really enjoy doing this, huh? Dr. Q, it seems like you really love this. And I'm so happy that I came to UCSF. I think it's probably the most meaningful and most rewarding.
So for trainees listening, especially the international grads, what do you want them to know?
So that's a very good question. So I'm going to repeat the quote that I heard from a senior of mine who I respect him a lot. He was also, same as me, he was international medical graduate. So he said that all things being equal, we're going to always get chosen after the U.S. graduates. And this is the fact. I'm not making this up. The numbers are there. In almost every specialty, the U.S. graduate, the match rate is going to always be higher. But I don't want this to discourage anyone. The sooner you realize this disadvantage, the better you're going to do long term. So you can accept this disadvantage. You know what work needs to be done to overcome this advantage. It could be more research, better performance during your residency, better letter of recommendation. You know, you need to do some electives, whatever needs to be done. You can set the goal and work towards it. And a lot of internal medical graduates that I know that start from zero, you know, have gone on to great programs by just knowing what they don't have and make up with what they can have.
Yeah, absolutely. And networking, like finding people who've made it through and learning from them and finding a mentor like that, I think that also would be very helpful.
Connection is everything too, as well. Yeah, totally agree.
Well, Dr. Kewcharoen, or Joe, as I know you, thank you so much for explaining about international medical graduates and about fellowship, residency, and the physician pathway. A lot of us don't know. I didn't know until I came to UCSF, honestly. So I so appreciate your time. I enjoy working with you, and I'm so glad you're here.
Well, thanks for having me. I'm super excited. I enjoy working with you and everyone in the team. I mentioned that I'm happy that I'm in EP, but even so, I'm very happy to be doing EP at UCSF.
Awesome.
The past year and a half has been a blast.
Thanks for tuning in to this episode of In the Loop with Nadia Vlasiuk. I hope you found today's discussion insightful and empowering. Feel like diving deeper into the topics presented today? Be sure to check out the show notes for references and more helpful information. You can also visit our Substack or Instagram, Facebook, and TikTok. Remember to stay curious and stay informed. Now you're in the loop.